Hey, welcome everybody. Now this may have been asked earlier, so let me kind of do it again. I wasn't here for the beginning. How many of you are soon to be fourth year students? Great. I need not ask any more questions. So, this is a great opportunity. I know looking back, I wish I had a med student symposium, and if you look around the room, you guys are all self-differentiated. You guys are all kind of here because you really want to get something from this conference. What Nick said, I would echo tremendously. It's a very welcoming community, and you should definitely not feel uncomfortable emailing any of us tomorrow, next week, and to be honest with you, some of us are going to see you on the interview trail. And, it's a very small community. So don't hesitate to contact us. So we're going to talk a little bit about some selected chapters in the EM primer. The nice thing is, I guess I do have a vested interest because I was the lead editor and author here, but it's free of charge. This is not proprietary. So this is posted on the cdemcurriculum.com website. And I think the real push behind this manual is really for students going into an EM clerkship, regardless of what their career paths or interests are. There's 24 chapters, and only one of the chapter really focuses on students with EM as a career interest, but the rest of the chapters are very applicable to really getting your mindset in the way it really should be to start your EM rotation. And I think you'll find that every rotation has its particulars, and certainly EM is one of them. So we're going to just talk about some kind of key aspects of some of the selected chapters. And I would say it's a very easy to read manual. Each chapter has some annotated references. They're 4 to 5 pages, kind of easily digestible, but it's also written in a way that I think is very different than any of the other textbooks on the market, because we don't really go into the details of how to manage chest pain or shortness of breath or back pain, etc. But it's really how to approach that undifferentiated patient, how to develop a differential, how to perform a focused H&P, how to go through the process of identifying what diagnostic tests, etc. Things that are not really, I think, talked about in much detail in various textbooks. So if you look at emergency medicine and really what distinguishes this field, it's a complaint-directed specialty. And it's very different than, I think, any other healthcare field that you're going to encounter. So what I would recommend from the get-go is read about chief complaints, right? Whether you keep track of the patients you see during a clinical rotation, read about them, or you have a month or so to prepare before you start your next DM rotation, read about chief complaints, read about the presentation, read about the key conditions causing abdominal pain or chest pain, etc. Think about the evaluation, the workup, the management, the disposition. That will slowly improve your fund of knowledge so that when you do see that belly pain case, you know the questions to think about, you know the differentials to kind of focus on. And again, there's a good chapter kind of focusing on both undifferentiated and quote-unquote differentiated patients. But you'll see primarily probably 3/4 of the cases you see in the emergency department are complaint-directed. Someone's going to come in with a chief complaint that's undifferentiated. You're going to have to decipher whether that belly pain case is benign, whether it's surgical, whether it's going to need some diagnostic imaging, whether you're going to need some laboratory tests, whether you're going to need some bedside ultrasound, and really kind of formulate that differential. And one of these chapters kind of clearly leads into the next. So when you think about undifferentiated patients, and again, we kind of, I think, portray this very well, is you got to think from the standpoint of stable or unstable, right? Stable patients, you had that opportunity to get a focused H&P. And I think the big difference going from some of your other outpatient rotations or even from a medicine floor rotation, you don't necessarily need to be overly comprehensive in your approach to these cases. You need to be absolutely thorough, but you need to focus down and really target that key information. Unstable patients, obviously early on in this situation, right, you got to notify your attending or senior resident and obviously get help. But the difference between, I think, EM and a lot of other rotations is if they're unstable, these patients need therapeutic management, whether it's IV access, high flow O2, antibiotics, fluids, whatever it ultimately may be. But if your patient's unstable, you need to pick up on that, and sometimes it's not quite as simple. Right, so undifferentiated cases, for example, maybe someone who's short of breath, if you're dyspneic, you may need, high flow O2 BiPAP. That person need to maybe needs to get prepared to be intubated, but ultimately you have to make that decision at the bedside whether they're stable or unstable. And I think that's a huge kind of axiom for emergency medicine. Now, it's certainly obvious, right? You walk into a patient's room and their heart rate's 140 and their blood pressure's 70, relatively obvious. Or someone who's unresponsive or severe respiratory distress or, in VTAC, et cetera. But sometimes it's a lot more subtle, right? Sometimes it's that person who is a little bit sleepy and you're trying to get a history and you can't really get anywhere, and your attending comes in the room with you, and within a minute they're calling for BiPAP because they know the patient's probably hypercarbic. So sometimes it's a bit more subtle. And there are times where there may be a trend. Maybe the patient was awake when you saw the patient, now they're a bit more sleepy. Now they're, things kind of change. So keep an eye on those subtle kind of presentations. You evaluate someone at 9 o'clock in the morning and they're having a hard time staying awake, maybe that's a bit of a problem. People that are intoxicated, people that have just vague, nonspecific complaints, sometimes kind of harbor things that are a little bit more serious. Now, where that kind of leads you is to the point of really doing a focused or complaint-directed H&P. And again, I'll tout another good chapter kind of in the primer that really can focus your approach to these cases. So what do you have to think about when you walk into the room of someone who's presenting, again, with an undifferentiated complaint? What's their general appearance? What do they look like? What their mannerisms are? How they're, what's their mental status, et cetera? Vital signs are hugely important. We had a case in our department a couple days ago that was signed out to me. The patient was already admitted to the RICU, so I really didn't have any management aspects to deal with. But I went back and talked to the patient just so I could kind of reiterate what the complaint was. And the long and short of it is, it was a guy with a long-standing history of interstitial lung disease on home oxygen who came in for what he thought was a gout flare. He had some lower extremity pain and swelling around his ankles and feet, not dissimilar to prior gout flares, but he was persistently tachycardic in the 120s. And the chief resident who was taking care of the guy initially thought maybe it's pain-related, gave him some analgesia, kept an eye on the guy, but he, over the next couple hours, was just persistently tachycardic. And then they went through a more detailed evaluation to try to figure out what's this persistent tachycardia. And again, with a guy who had very poor pulmonary reserve, who even at baseline was, somewhat dyspneic on home oxygen, ended up having a submassive PE. And it's something that, if you overlook those subtleties, at some point they will come back and bite you. So early on with the guy with a heart rate of 120 with some leg pain, all right, you get it, do a good cardiopulmonary exam, go through a focused cardiopulmonary history, and maybe if his heart rate resolves with some analgesia or a little bit of fluids or whatever, that's one thing. But again, vital signs, and it's not just the isolated number, it's the trend. You got to see where things are trending. Sometimes they trend in a positive direction, other times they don't. As we talk about your H&P, remember, comprehensive is not necessary, maybe with a couple of caveats or exceptions. You evaluate a 86-year-old woman who feels weak and dizzy, you have to cast a very, very wide net. But for most people, again, you want to be systematic and thorough, but you want to focus your evaluation. I think what you'll find over time, as you start developing more pattern recognition and kind of, you've seen many, many cases of similar presentations, you can be very thorough in a very short period of time. So I think the challenge many times at your level as a fourth-year student is deciphering what's important, what's not important. And again, that just takes some time and experience. And again, don't forget there's also time constraints, right? You don't want to get locked in a room with a patient for 30 or 40 minutes trying to go through your initial H&P. We kind of tell our students typically, it's like that 10-minute rule. Really, I kind of use this 10-second, 10-minute rule. You walk into someone's room and they look unstable, you probably have about 10 seconds to reevaluate them quickly, go get your senior resident. Otherwise, don't spend more than about 10 minutes. If you can't figure out what's going on generally in about 10 minutes, I'm not sure much more time is going to make that much of a difference. So differentials are another challenge. I personally find it challenging to develop a clear, concise set of differentials for many cases that you see, especially belly pain. For me, that's like a great example. Why? Because more than half the people I see with abdominal pain leave with a diagnosis of nonspecific abdominal pain or abdominal pain without cause. So the bottom line is you should be thinking of key conditions. And I ask this when I have my student orientation, which we actually just had this past Tuesday. You know, a lot of you know a lot more book information than maybe what you know clinically. If maybe I ask the room for a second, how many of you have been involved with the preliminary diagnosis of a patient who presents with a newly diagnosed pulmonary embolism? All right, a few, actually maybe more than I would have thought. But most of you probably know Virchow's triad and kind of know the classic presentation. And I think what you'll find many times your differential kind of early on, especially with more junior learners, it's more what you know than maybe what you've seen. So that's why experience and volume and seeing lots of cases will definitely add to your funded knowledge. When you're formulating your differential, certainly before you're presenting your case to your faculty member, you should in your own mind be thinking about both life-threatening to most benign and also most likely to least likely. You should always be thinking that way. So every case that I see, chest pain, back pain, abdominal pain, headache, etc., I'm always floating around those two or three things in my mind that could be potentially life-threatening. Now again, if your most likely diagnosis is the most life-threatening, big problem, right? You see that 75-year-old man with, you know, abdominal pain radiating to the back who's hypotensive and tachycardic. If AAA is not on the top of your list, you're kind of missing something. So again, luckily, most of the time, it's not going to be that life-threatening condition. But you got to kind of have that kind of dual list that you're focusing on. Now, your plan of action, again, stems from stable or unstable, right? If your patient is non-urgent, they're hemodynamically stable, they're not in any respiratory distress, focus your history, focus your physical, develop your differential, think about what your management plan is. And I think the biggest thing at this stage is, remember, as a, you know, second to third year medical student, you should be able to report that information. You know, getting into your third year, you should be able to interpret that data. But as a fourth year student, kind of coming into your sub-I or your required rotation as a fourth year, you should really be able to start thinking about managing that particular case. So what you want to make sure during your presentation is that you're forthright with your assessment and your plan. Because often, you know, you want to get that information out and obviously take ownership. As we mentioned, if the patient's more urgent or if there is an emergent condition, again, at this stage, you go get help, but ultimately, for a number of conditions, you know, sometimes action speaks louder than words. So diagnostic testing is a big thing, and you'll run the gamut from some patients need absolutely no diagnostic testing, and some people need a litany of laboratory studies or diagnostic imaging. And I think the big question you got to ask yourself is, you know, what is that test going to do for that patient's care? And ideally, although it doesn't obviously always work this way, is when you have a set of differentials, there are certain things on your list of differentials that a diagnostic test can either help rule in or rule out, right? That would be ideal. But again, if you have that elderly patient who has very nonspecific complaints, you may not even have a clear list of differentials. But again, some cases you do have to cast that wide net, but you want to try to get into the habit, if you're able to, of justifying why you want to get a particular diagnostic test. What are you going to do differently if the test result comes back positive or negative? Case presentations, probably from my standpoint, certainly with you entering this stage of your career, by far the most important thing, right? Because if you look at it from a standpoint of what your preceptor is getting out of this, most times your preceptor is not going to go in the room with you and watch you or directly observe you perform an H&P on the case. It's just not realistic based on time constraints and faculty resources. So your case presentations really is a surrogate marker, right? It's a way for your preceptor to get a sense of how well you have gathered that information, analyzed it, and can kind of put it back in a digestible format. So if you are struggling or trying to get a better handle on learning how to do case presentations, I would actually probably recommend a little bit of shadowing with some of the second or third year residents to kind of get a sense how they present their cases to the attending. Now, most cases, right, are typically presented in that traditional format. Hey, Dr. Wald, I have a case of a 56-year-old male with a history of hypertension who presents with 2 hours of left-sided chest pain associated with shortness of breath. He reports while he was at work earlier today, blah, 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 blah. I mean, very kind of standard and straightforward, where you take the pertinent past medical history, incorporate that into that opening statement with their chief complaint, then you expand on it with key aspects of your, HPI and pertinent review of systems, and then you could add whatever other additional data goes into your physical exam, et cetera. Now, what I would tell you is that's probably the way you should be presenting most of your cases. What you have to realize is for emergency medicine, one challenge, I think, from an educational standpoint is there's a lack of preceptor continuity, right? So if you're on an inpatient service, it may be common for you to have the same inpatient attending for 2 to 4 weeks. When you're working as a student shift working in the emergency department, it's probably more likely that you'll have a different attending almost every shift. Some attendings like you to present cases in a very particular format, and it's probably not until you present a couple cases to them do you kind of get a sense how they like things presented. What I would tell you is you do have potential opportunities to present assessment-oriented presentations. Anytime you call a consult, anytime you call an admission into the hospital, that's definitely the way you should present your cases, right? So if you have a young man who presents with lower abdominal pain, now it's radiating to the right lower quadrant, nausea, low-grade fever, anorexia, you talk to your attending about the case, you guys both go back and reevaluate the patient, you get some diagnostic tests, you get a CAT scan, the patient clearly has acute appendicitis on CT. When you call your surgical consultant, the first line out of your mouth should be, "Hi, this is so-and-so, I have a consult for you in the emergency department for a patient with acute appendicitis." You give the assessment up front. You do not have to reiterate the whole entire history because they're still trying to figure out what's the end game, what are you calling them for. There's nothing wrong with providing them that initial assessment and then giving them a little bit of the backstory afterwards. But if you are comfortable in your evaluation of certain cases in the emergency department that are often kind of single system, straightforward complaints, and you're comfortable with your interaction with the attending, you may be able to present some of your cases in an assessment-oriented fashion. I mean, if I see, a student presenting a case to me, let's say of a patient who really clinically has, an ankle sprain, and they present the case to me, of a 36-year-old male who had an inversion injury, who they feel has a ankle sprain, I mean, they've already kind of digested that information and put it back to me. I mean, we're going to definitely talk about Ottawa foot and ankle rules and whether the patient needs imaging or not. But again, I think if you are comfortable and you have that relationship with your preceptor, you should consider trying to present some of your cases in this particular fashion. Now, there is a great video, and I would certainly refer you to this. This was a combined effort with CDEM and EMRA. And it kind of goes through a little bit more of a traditional case presentation format. It stars, who I don't see in here, Dave Gordon, who's one of our past presidents of CDEM. And it's a great kind of primer for getting a sense how to do kind of an EM-based case presentation. Another challenge, I think, what you'll find with emergency medicine is you're probably coming to a rotation like this so fixated on being able to make that definitive diagnosis, and you will be let down because there will be lots of cases that you see that you won't be able to make that definitive diagnosis. I would tell you that certainly in my experience, I'm much more likely to tell a patient what they don't have sometimes than what they do have. So, and again, abdominal pain is the greatest example, right? I can feel very comfortable at the end of my evaluation that they don't have pyelo, that they don't have, biliary colic, they don't have a kidney stone or appendicitis, et cetera. But why they're having their abdominal pain that's been on and off for 6 months, I'm not going to be able to make that diagnosis. So you kind of have to accept the limitations of our specialty and realize that you may not always definitively be able to make a diagnosis. Many times it's not actually necessary to make that diagnosis. It's probably more important to exclude certain things. But it's real important, I think, the way you explain this information back to your patient. So it's not a good idea to be like, hey, there's nothing wrong with you today. There obviously is, because they wouldn't be in the emergency department. But it's the way you kind of present that information back to the patient that also will allow them to feel that they're getting something out of your visit. Consults, obviously very important. Probably hard to pick a number, but I would imagine probably 15, 20, 25% of our cases at times deal with consultants. You're dealing with consultants based also on a non-urgent all the way to an emergent basis. Be wary of their time and kind of what you're calling for them. It should be very goal-oriented, and again, your presentations to your consultant should be assessment-oriented. And again, be wary of kind of calling people in the middle of the night unless it's absolutely necessary, because again, many of your consultants also work that next day. One thing that is important down here is speak your consultant's language. Don't call your orthopedist without the x-ray and being able to kind of describe that appropriately. Same thing with the EKG or the chest radiograph or whatever that ultimately may be. Now, I think I'm going to leave you here with this kind of last slide, and to me, this is one of the more important slides as you're going through your process of care for patients. You should be thinking about these questions every time you see a patient and in preparation for your case presentation. Because if you're not forthcoming with what your assessment and what your plan is, I guarantee your preceptor is going to ask you, well, what do you think is wrong with the case? What do you want to do? And you have to think beyond that first step of diagnostic testing. I mean, I get cases presented to me all the time, and it's not just at a student level, maybe it's at the intern level, of a low-risk chest pain patient that they want to get an EKG and a chest x-ray, troponin, et cetera. And then my question is, well, what are we going to do if the troponin's normal? And then there's this awkward silence for like 30 seconds. You should be thinking beyond that initial workup as to what you want to do. And sometimes that actually can guide your diagnostic evaluation. So I wish you luck. Thank you for allowing me to come up here. Please feel free to contact me at, by email.